Thank you, Nathan, and I think there's probably an enormous number of questions I'm going to be answering in this session. But I am going to try to stick to my 10 minutes of time. I have my phone in front of me. 13:07, okay. The last day and a half, yesterday I was very sick and cranky, and unlike Stephen, my friend Stephen Lewis, who sadly had to leave, but we talked at lunch about my presentation today. When I get cranky, I tend to go quiet because I'm afraid that I'll either burst out crying or start screaming and ranting and raving. So, but what has been very fortunate, from why I have been very fortunate in being very uncharacteristically quiet in the last day and a half, has enabled me to really focus and listen to the incredible presentations and discussion that have happened over the last couple of days, and certainly Wafa's initial presentation and Brian Williams' riveting presentation yesterday morning set the tone. But I've also been really impressed about how much clinical and operational research is out there right now looking at the impact of treatment on prevention in countries throughout the world, particularly as they struggle with the enormous challenges to move from treating people below 200 to treating people according to WHO 2010 guidance below 350 CD4s. And I was particularly pleased as well to hear the conversations move through the past 2 days towards discussions around equity in access for key populations, and discussions around regional issues, and then discussion around the human rights challenges of scaling up treatment and achieving universal access. I guess I just need to put out there one big disappointment that I've had, and I put it out there because WHO, I take responsibility at WHO and UNAIDS, as well, I think, as other supporters of this conference, really made an effort to try to bring more people working in developing countries to the meeting. And in fact, it's been great to hear from people like Peter, the National Program Manager in Kenya, and Papa from Senegal, and our Chinese colleagues, and Sergey from the Ukraine, Vietnam, and I think there's a colleague here from Zambia. And I'm really pleased that Paul was able to get his visa to join us as the community respondent in this session. But I'm still disappointed how few people there are from developing countries at this meeting. And I know from the experience of trying to get people here that one of the reasons, of course, is visa challenges. And this country, and I speak as a Canadian so I can criticize my own country, has become at least as, and if not more difficult to get a visa to come to from a developing country, particularly because we have fewer consulates and embassies around the world. But also, a number of the people that we approached, particularly national program managers in developing countries, expressed very kindly and respectfully that they were unable to attend. But the message that I got was that at the moment, treatment as prevention is not their biggest priority. Their biggest priority is to try to treat the people most in need for their own health. So I hope that as we go forward outside of this meeting, that we find opportunities soon to really engage, particularly people that are managing treatment programs throughout the world in developing countries. I need to, before I go into, I only have 10 slides, so don't worry. I think I do need to respond somewhat to Stephen's comments on the opening night. And just to say that when I was approached 6 months ago by my boss and friend Gottfried Hernschel, the director of the HIV department, to come into WHO for a 6-month period, which passed about 3 days ago, to help with getting treatment 2.0 off the ground and to coordinate the treatment and care program, my initial thought was that I would rather stick knitting needles in my eyes And I keep those knitting needles beside my bed every day. Why would my response be that? Well, it's no secret that there are enormous challenges at WHO in terms of management challenges, bureaucracy challenges, challenges around financing, the fact that our core contributions are only 20% of our budget, and 80% of WHO's budget comes from voluntary contributions. We're fortunate that some donors, and in particular the Gates Foundation, the Bill and Melinda Gates Foundation, do prioritize HIV, have their own priorities within HIV, and so we're fortunate in that regard, but we face enormous challenges at WHO. As I got on the plane on Tuesday to come here, we announced, the senior management team, to our staff of 62 that 22 of them will be gone within the next 2 months. When I last worked at WHO in 2003 for a year at the beginning of the 3x5 initiative, we had over 100 staff. And if I just give you very quickly a picture of what that looks like, in the treatment care and support team that I coordinate, where we have 9 people now and we'll have 6 people, we oversee the drug resistance monitoring and prevention program, the global pharmacovigilance program, antiretroviral therapy guidelines for pediatrics and for adults, work on TB, HIV, antiretroviral therapy for prevention, and that leaves out, of course, all kinds of areas of care and support that WHO should be looking at. We don't address palliative care. We're barely able to address hepatitis in the context of HIV. We're barely able to address issues around nutrition, service delivery. So we face enormous challenges. And I think this reflects the enormous challenges that face the HIV field at the moment. And this is my call for taking the gloves off, particularly when we leave this room, and my call for keeping our gloves on when we work together in this room, all of us working towards the goal of eliminating HIV in our lifetime, if we can, if not, in the lifetime of our children. And there is more of a need now than ever before for activism and advocacy for more money to address HIV, particularly now that we've finally made progress in this epidemic. We have over 6 million people on antiretroviral therapy. We have prevention programs throughout the world that are beginning to work. So we have to remember, and we have to go out and fight and say, our job is not done. Do not get bored with AIDS, donors. We have more work to do. We want to end this epidemic. On that note, I want to move into talking about treatment 2.0 and why I decided that I would rather work for WHO than stick those knitting needles in my eyes. I believe that unless we are able to radically simplify treatment, we will not be able to sustain universal access for people who need treatment to protect their own health, nor will we be able to expand access to achieve the secondary benefit of preventing HIV transmission. It's not just an issue of cost, but it certainly is an issue of cost. We don't have enough money, barely, to keep the 6 million people on treatment today continuing to take their medication. A reality check that there are still at least a couple of million people out there today who will die within the next year without therapy. And then there are another 6, 7, 8 million people who are eligible according to current guidelines. The enormous human rights challenges that people face who need therapy prevent the programs from doing the job that they need to do. And the technical and operational challenges of delivering what is still far too complicated make it impossible in my mind to achieve sustain universal access and move beyond that to treating people even earlier. So Treatment 2.0 is a program that is aimed over the next 10 years with a short, medium, and long-term agenda, and I've already gone over my time, I can't believe it, but I'm going to race through this now, to radically simplify HIV treatment. Now, what the dream, of course, would be that we were able to rapidly diagnose HIV with tests that also showed acute infection, offer treatment immediately to everyone who was HIV positive, deliver that treatment for the rest of their lives, harmonize regimens so that we gave the same first and second line treatments to all children, to all people living with HIV, whether they were pregnant women, other adults, children. Right now, we do not do that. It's far too complicated. We would want at minimum 1 pill per day that was heat stable, fixed dose combination. We would want simple monitoring tools, and we would want to be able to deliver treatment in a decentralized, integrated way with other areas of healthcare, through primary care, through antenatal services, through TB services, through harm reduction services, to move away from standalone ART, and we would want nurses and community health workers to be able to initiate and monitor treatment. So how can we get there? The Treatment 2.0 initiative is one opportunity for us all to come together. There we go. Now, just a bit of history quickly. Remember that the public health approach to antiretroviral therapy that was put forward in 2002-3 by WHO and UNAIDS very much called for simplification, standardizing the treatment protocol, using optimal use of human resources, involving community, minimizing costs, protecting human rights. So we've always, in some ways, been driven by the need to simplify treatment. This slide has been shows that dramatic increase over the last 8 years. Everybody should feel proud of that. Everybody should remember what it took to get there and not just focus on how much further we have to go. These are 2009 numbers. In about a month, UNAIDS and WHO will release much better numbers, well over 6 million people on treatment as of the end of 2010. But if you look at those top bars, we've made enormous strides in sub-Saharan Africa, but in particularly in the Middle East and North Africa, in Eastern Europe and Central Asia, treatment coverage is abysmal. What are the challenges to narrowing that treatment gap? We've talked about the costs, We've talked about the costs. I mentioned the complexity ongoing of treatment, inefficiencies and fragmentation in service delivery, the challenge to treat earlier to improve and achieve broader health outcomes and to maximize the HIV and TB benefits of HART, and transition from what's been an emergency response to sustained chronic care. Nathan, you asked me a question. So what are the goals of Treatment 2.0? The ultimate goal is to achieve and sustain universal access to antiretroviral therapy for all people who need it. The second goal is to maximize the HIV and TB preventive benefits of ART. What has changed from that first publication back in June to our later publications and the way we're working is the work streams to get there. So our goal, universal access, optimizing and maximizing preventive benefits of ART. How do we get there? Through 5 priority work streams. I'm just going to talk about one and then turn to David, who will talk about the other 3 of the others, and Paul will talk about the 5th. But all of them are interrelated and neither take priority over one another. So optimizing drug regimens, promoting diagnostics using point of care and other simplified technologies, reducing costs, adapting delivery systems, and mobilizing communities and protecting human rights. If we can achieve all of those work streams together, we believe that we can achieve and sustain universal access. We held a meeting. WHO is responsible in the division of labor of the UNAIDS family for treatment, and we held what we call the Interagency working group on treatment a couple of weeks ago, and asked the members of that group to identify what within those 5 priorities, what areas they're working on. So this gives you a bit of a reflection. I'm not going to go through that in detail. We also held what was called a core external partners meeting with UNAIDS to look at the 5 priority work streams and who was taking the lead at the global level. And as you can see, the agencies present at that core meeting identified the primary areas that they're working on. So on drug regimen optimization, Gates Foundation is a major funder, the Clinton Health Access Initiative, the medicines patent pool created by UNITAID last year to ensure access to future innovative therapies through pooling of patents by companies developing those products. UNITAID, who really plays a critical role, a new role in funding, early funding of new technologies before larger funders, implementing funders like PEPFAR and the Global Fund, and countries themselves kick in to finance implementation. And then the NIH obviously plays a strong role in terms of research, particularly supporting basic research towards development of new products. So what do we want to do around optimizing drug regimens? Mobilizing innovator generics and API companies and other organizations to stimulate the pipeline. If you look at the research pipeline for HIV drugs, it is not as healthy as it once was. The number of new products that will come onto the market in the next few years is really pitifully small. We want to optimize the currently available drug regimens, and that's what I'm going to focus on in the last 2 minutes of my talk, as well as develop new products. And with the lens of harmonizing the preferred first and second line regimens, as I mentioned before, for all people living with HIV, towards a target product profile of a drug regimen that's potent, robust, has minimal toxicities, high barrier to resistance, minimal drug-to-drug interactions, and that at the most is 1 pill per day fixed dose combination. Here are some of the strategies that are being employed. I mean, optimization of antiretroviral therapy is really today looking at reducing the pill burden and pill size, the toxicities, the drug interactions, limiting monitoring needs that's safe to use across populations. We believe that will lead to improved adherence and clinical outcomes, make it more convenient, and reduce the costs. And in the bottom of this graph, you see a number of activities related to short-term optimization of antiretroviral therapy. Because I've run out of time, I want to give you quickly a sense of where things might be headed in terms of WHO guidance. First of all, we've made a commitment to integrate and simplify our own guidelines. Wouldn't that be great? So working towards 2013, we want to bring together what have been standalone guidelines on PMTCT, on infant diagnosis, on treatment of pediatrics, and on adult treatment towards a more integrated guidance package. The triple pluses mean a very high impact, and in the next 2 period, what we call the short-term period for treatment 2.0, we see leading up to 2013 guidance, and I need to say that there is guidance along the way. We don't wait until 2013 if something happens, but leading up to integrated guidance in 2013, which for the first time will incorporate service delivery issues as well as what to start with and when to start. We see that there will likely be many more fixed dose combinations and improvements in terms of the chemistry process, particularly a trial looking at tenofovir process chemistry, which would reduce the number of steps involved in producing tenofovir, which would dramatically reduce the price. By 2015-16 guidance, we'll see new formulations and the results of some dose reduction strategies of a number of different drugs. And by 2020, we'll have new drugs and new strategies aiming towards, if you look at this graph, it's a bit of a busy graph, but will guidance in 2013 be above 350? Question mark. Things are certainly seem to be heading in that direction. and 2016, there are already a number of fast-track situations where anyone who has HIV is eligible for treatment. Right now, people with TB, people with HBV, all children under 2 years of age. And moving towards, by 2013, from 1 to 4 pill burden first-line treatments to 1 to 2, and pill burden down to 2, from 3 to 6 in 2010. We're trying to aim towards limiting the preferred first and second line options. In 2010, there are 4 for first line and second line. By 2013, we hope that there will be preference for 2 to 3 regimens at most, and by 2016 down to 1 to 2. I guess I'm going to finish there, because I do know, Nathan, that I went well over. I never explained to you why I called my presentation Kiss or Miss. Anyone who grew up in Canada or the US, as I did about half a century ago, will remember that at school we were always told to keep it simple, stupid. And so when I wake up in the morning, I say to myself in this job, keep it simple, stupid. And if you can't keep it simple, stupid, then make it simple, stupid. So maybe the stupid is a bit derogatory, but what I urge everyone in this room and everyone working in HIV to work towards in the coming years is to make things simple. Thank you very much.